and thank you very much to GEA LSP for organising this seminar. So I'm co-chair of the Independent Accountability Panel for the Secretary-General's Global Strategy for Women, Children and Adolescent Health. And just very briefly, the global strategy, there was a first one launched for the acceleration of the MDGs, particularly MDGs 4 and 5 in 2010. And with the advent of the SDGs in 2015, the global strategy was renewed and updated towards the SDGs, with indicators aligning with the SDGs, and importantly to include adolescents. So it's women, children and adolescents' health. And the role of the Independent Accountability Panel, which has 10 members from across the globe, is to look at the progress of women, children and adolescent health towards the SDG indicators across survive, thrive and transform. So the indicators go across these three levels. As such, the panel was preparing their 2020 report for a review as to what the progress in women, children, and adolescent health is for launch this year when the COVID crisis hit. And so what we have done is to look at the progress, but also to look at what the implications of the COVID crisis are on the progress and whether it will further stall or have what sort of impact it can have, and what can potentially be done in order to ameliorate that impact. We have looked at inequities across these three areas, women, children, adolescent health, and we've also looked at some and undertaken some case studies. So I think to start off with, maybe just to say that already prior to COVID, there was round about a 20% progress lag towards the SDGs for women, children, adolescent health. Now, just looking at, I'll go into looking at some of the individual targets at in a minute, but some of the issues were that less than half of the world's population have full coverage of essential health services. Obviously including those for women, children, adolescent health. Over 900 million people were debilitated by catastrophic health expenditure. And that almost goes without saying that it is the poorest that suffer from these catastrophic health expenditures when they become ill. And the universal health coverage differences between countries is also seen within countries, depending on geographical settings, on wealth, on sex, on education. So all of the different parameters show inequity across the access to services and the resultant indicators. So the other thing maybe just to say is that globally, mistrust was pervasive, driven by the growing sense of inequity and unfairness, and people themselves distrust the government. They distrust the private sector, they distrust the media, and they distrust, the issues around whether they themselves will be able to be equally treated or treated with an equitable sense. And was a growing sense that the global economy is geared to making profits for the few at the expense of the many. And so underlying this is the situation once the COVID pandemic struck. And what has been clear to see that in rich and poor countries alike, that the health systems were unprepared, that the inefficiencies, the ineffectiveness and the inequities are being compounded And we can see this, that very few countries have made good decisions in terms of the response to COVID-19 and are able to cope in a sense in which they have the trust of their people and are able to have kept the number of cases and number of deaths. I won't go into which ones those are. I think we all know them. But now we see that there are further risks to the health of women and children by the very policies that have been taken by countries to reduce the spread of the virus, which, if they had actually been well prepared in the first place, they may not have had to undertake. So maybe to go into a little bit of detail here, countries have gone into lockdown. More than 166 countries with billions of people under lockdown. An estimated at least 10% reduction in contraceptive prevalence. Women can't get access to their contraceptives. If they can't get access to their contraceptives, they're at risk of unwanted pregnancy or unintended pregnancy. If they're at risk of unintended pregnancy, then are they able to get access to abortion, or do they resort to unsafe abortion, or do they continue with the pregnancy and then be potentially at risk of death or other complications during delivery? So there is an estimation that potentially there could be an extra 28,000 maternal mortalities on top of the already 300,000 that there are each year, and potentially 168,000 newborn deaths on top of the 2.6 million newborn deaths that are already occurring. Another effect on women is domestic violence. We have already seen that there is an increase in the prevalence of domestic violence during the lockdown, and that particularly affects the poorest women. In the UK, they've seen a 50% increase in death from domestic violence in the first 6 weeks of lockdown. They monitor that closely, and they have now put in place extra funding, but in many countries, the situation of violence in the home is not receiving the attention that it needs. And in children, we've already heard from Lawrence that they are at risk of undernutrition, but vaccine programs, are they able to access their vaccinations? And if not, will the countries be able to catch up with the vaccination in time before there are epidemics? We have already seen measles outbreak prior to COVID-19. Will they be able to catch up, or will there be further outbreaks of other vaccine preventable diseases? We've already heard about the malnutrition and the issue around access to safe childbirth practices. Can the women actually get to the facility, and is the facility safe for childbirth? And will there be not only further maternal mortalities, but stillbirths and neonatal mortalities? We've heard about school closures, adolescents and young people and their issues around learning, but however, they may also have face greater exposure to physical threats. Social isolation may exacerbate mental health issues. There are reports that there is increased female genital mutilation, and the numbers have soared in countries such as Somalia during this lockdown period, because the children can't escape and they are not in a safe place when they're at school. We know that health systems and the health facilities have been overwhelmed by COVID-19 cases, and have they put in place a red zone, a green zone for the uninfected and the infected? And what does that say in terms of people's perception and people's utilization? Where it is closely monitored, there has been a dramatic drop-off in service users who would normally use the service, but are not going because they're afraid. They're afraid that if they use the service, maybe they will get infected. They're also afraid to go out of the house because they've been told not to. So a combination of factors is actually reducing the utilization of services. And then the issue of rights and accountability. COVID-19 in some countries is being used as an excuse to suppress human rights and to exacerbate, and where human rights are already flouted, then it is exacerbating issues in those countries. We saw a beautiful picture from Brenda on health workers being clapped and applauded, and in many of the high-income countries, there is clapping and applauding of the health workers. However, in some countries, health workers are facing stigma and discrimination, including losing their homes, because people are afraid and they think that they are the ones that are spreading the virus. So communication and issues around communication is having a devastating effect on the health of people, and particularly the health of women and children. We have within our report looked at the mortality rates for women, children, adolescents, and have prepared league tables based on countries' income. And we see that according to the country's income, we've put the countries into 4 income groups, there is vast difference in countries' performance, notwithstanding their same level of income. And of course, from the top to the very bottom, there is at least a 500 times risk of maternal death from 2 at the lowest countries such as Norway, Poland, Italy, to over 1,000 per 100,000 in countries such as Sierra Leone and South Sudan. So we also have seen that in countries such as Tanzania and Nigeria, both countries in Africa, both spend the same amount on healthcare. However, Nigeria has double the mortality for children than Tanzania. And so one wonders why this difference and why this inequity, and partly it's due to distribution, because the spending itself doesn't necessarily tell you exactly what is happening. It gives you an indication, but it doesn't look at the inequity within the country. You need to look at the spending as well as what the differential is within those countries. Finally, before I look at the way forward, just briefly looking at issues such as birth registration and the issue of data availability. We still find that 1 in 4 children today are not registered at birth, and that certainly has implications for later on their school registration. And the issue of registration of deaths. We've seen within the COVID-19 response the great disparity in the way countries are reporting deaths from COVID, which deaths they're reporting. And there's a lot of discussion around that. But there isn't the same discussion around whether or not countries are reporting the death of a woman during pregnancy. And still we find that many countries are not reporting the cause of death. So they're not reporting whether a woman has died during pregnancy or not. We're still relying on estimates rather than actual figures. So where do we go from here, and what are the implications in moving forward? What can be done differently? First point is we need to invest in data collection. And I think that we need to build on the opportunities that are coming in through the COVID crisis to develop further within all countries the data collection systems and having relevant live data in terms of birth registration, death registration, and cause of death registration. Secondly, we need to institutionalize accountability. We've heard a lot about accountability during the COVID crisis, much blame, much finger pointing, but fundamentally there is a need for institutionalized review processes, particularly in the case of emergency, but as a fundamental where our health systems are going. And finally, we need to democratize accountability to include the voices of people from all countries. We need to build independent accountability into systems through monitor, review, remedy, and act, and particularly so that those with the least voice actually have a voice and are able to access the services that they need. We will be producing, say, the report in the middle of July, and we certainly will be making it available for you so that yourselves plus all of those that are on this webinar will be able to see it. Thank you.